So the name of our training today is Mental Health Matters in Early Childhood. We have a few incredible speakers with us today I want to tell you a little bit about. We have Dr. Megan Lukasic, and we also have Dr. Yanin Guo. And I'd like to tell you just a little bit about them, and you can look at these highlights on your screen. So Dr. Yanin Guo is a postdoctoral fellow at Rady Children's Hospital Developmental Evaluation Clinic, where she provides comprehensive evaluations for children 0 to 5 with developmental, mental health, medical, and family needs. Yanin completed her postdoctoral training at CARES in New York, where she provided diagnostic evaluations and therapy to individuals with developmental disabilities. Additionally, she conducted group therapy with parents and caregivers to discuss developmental milestones and address behavioral and social emotional concerns. Yanin is also a board-certified behavioral analyst and specialized in working with individuals with autism spectrum disorder before starting her doctoral program. Yanin received her doctorate in applied clinical psychology from the Chicago School of Professional Psychology, San Diego. I want to tell you just a little bit as well about Megan Lukasic, who is a licensed clinical psychologist since 1998 and has worked at Rady Children's Hospital, where we are coming to you from today, since 1999. Megan specializes in the assessment of infants and young children. She has extensive experience in diagnostic assessment of neurodevelopmental disorders and early mental health concerns, including childhood trauma. In addition to providing direct clinical service, Megan manages the hospital's developmental evaluation clinic and is the co-trainer director for the clinic's APIC-approved postdoctoral fellowship program. She is the former clinical director of Rady Children's Kid Start program, a program for children ages 0 to 5 with complex developmental and mental health needs. All that to say, you are all in incredible hands today, and we are so looking forward to this conversation. So thank you both for being with us.
All right, thank you so much for the warm introduction, and thank you everyone for being here for this presentation. We're very excited to share all these information with you, and hopefully this will be a really helpful training and open up the doors for other talks and presentations and really just sharing resources in the community. So before we get started, we would like to take some time covering some of the items that we will be spending time talking about today. As the name of our presentation indicates, we'll spend some time talking about, why mental health matters in early childhood, and then why it's such a unique, needs for us, and then why, kind of like looking into its unique impact. And then we'll look at some of the signs and symptoms that are commonly associated with these early mental health conditions. And then we'll also take a look at, the history of mental health assessments. And then we'll spend some time specifically looking into the impact of trauma, which I know a lot of you are very interested in. And because we are talking about early childhood, so when working with this population, there are some commonly seen developmental disorders as well. So we'll take a very brief overview to look at some of those, including autism, attention deficit hyperactivity disorder, also very briefly on fetal alcohol spectrum disorder, looking at some current statistics or signs and symptoms for early childhood depression and anxiety. And then at the end, we'll end the presentation with talking a little bit more about resilience and protective factors when working with this population. All right, so now we would like for everyone to meet Jim, who is currently 26 years old. He's incarcerated and has very limited support from family or friends. And Jim has a history of violence and also a prolonged history of drug and alcohol abuse. So now if Jim were to come to our clinic right now, what were some of the things that you would want to ask him? Or what are some of the things that you're thinking about that you can work on with him? But before we do that, we would like you to meet Jim, or possibly take you back to, meet little Jimmy, who was 10-month-old. So Jimmy at 10-month-old, he was removed from his parents' care at birth, and he was, in his third resource or foster care placement. There was a family history of domestic violence, and he was born prenatally exposed to drugs and alcohol. So there was prenatal exposure to different substances. So, what we want to really tell you here is that the time to act is now. We don't have to wait, right? We don't have to, and we shouldn't wait. We shouldn't wait to see what happens. If you have someone, or if you meet a really young child or a baby that has gone through all these traumatic events, we need to intervene right now, so that, because we know what could happen 20 years later. So we don't want to wait. And then the time to act is now. And let's look at some current statistics on the mental health numbers. So among adult and adolescents right now, 1 in 5 experience mental health illness each year. And among those people, 1 in 20 experience serious mental illness each year. And then when we look at adolescents or young, or youth between the age of 6 and 17 years old, 1 in 6 experience a mental health disorder every year. And then 50% of those are lifetime mental illness, and they begin by the age of 14. And then 75% of them begin by the age of 24. And then suicide is the second leading cause of death among people aged 10 and to 34. And then research has shown that there has been a significant increase in terms of suicidal rates among teenagers and young adults. So it's really something that we need to be thinking about. Now, let's look at some numbers for younger children. So ADHD, behavioral problems, anxiety, and depression are among some of the most commonly diagnosed mental health disorders in children between the age of 3 and 17. So about 10% of them, and then that's approximately 6 million children, have received a diagnosis of ADHD. And 9.4% of them have diagnosed anxiety, and about 9% of children within that age group have a diagnosed behavioral problem. And about 4.4% of children in that age group have diagnosed depression. And really, the current statistic shows that 1 in 6 children between the age of 2 and 8 years old, that's 17.4%, had a diagnosed mental, behavioral, or developmental disorder. So again, we're seeing really an overall increase over time with our depression and our anxiety rates.
And Jan, and if I could, I'm just going to jump in here and say that there is a little blip on the screen here that the ages 3 to 179 is not correct. We're actually talking about and really focused on 3-year-olds up to 17. So, but pretty alarming statistics and growing. And I think we've all seen in our work the impact of recent events with the pandemic and so many other things going on in our world, how it's impacting even our youngest children. We go to the next slide here and jump in, because one of the things that's important, as Yanan said, is the time to act is now. And even though we may be working with very young children who aren't talking yet, there's a lot we can tell about them that tells us that it's time to act. I have a brother-in-law who's very, very bright. And I was talking to him one day, and he was telling me I was telling him about the work that I do. And I said that I worked with kids, mainly birth to 5, and that I worked in the area of early mental health. And he said, well, if they're that young, how can you possibly identify any early mental health signs? And my answer to him was, well, you look at the way that they eat, sleep, and poop, because those are the 3 things that little ones do all the time. And if any one of those things are not going the way we expect, there's a problem. So we don't need for them to tell us that something's wrong. If they're eating too much or too little, if they're eating nonstop. I was working with a little one this morning and just constantly shoving and pocketing Cheerios into his mouth. That's not a typical way to self-feed, right? With sleep, they're having trouble with sleep onset, difficulty falling asleep, or waking up multiple times a night. We want to pay attention to that. Or if they're sleeping too much compared to what we would expect. Pooping, if they're, we talk about poop when we talk about little ones. So if, they're constipated or they have diarrhea, we want to pay attention to that, because that could be a way that their bodies are telling us that something isn't right. So when we think about diagnosis, we can be really kind of happy and proud to know that we've come a long way with recognizing not only the need to really think about and talk about mental health, but also to talk about it when it comes to our very youngest children. And here is just a little history lesson about the different kind of our path that we've had in terms of diagnostic classification systems. So in the late 1800s, 1893, we had the International Classification of Diseases, or ICD, and it launched its first book and mainly focused on medical diagnoses. And we started there. And over the years, went through different revisions of that book, but kind of recognized by 1952 that, or shortly before that, that what was missing in that big book was any recognition of mental health disorders. And so in 1952, our Diagnostic and Statistical Manual, the first edition, was born. And then every 10 years or so, we'd get some really smart people into a room and they would talk about our current diagnoses and they would redo them and make edits. And we would have new editions. And that continues on. Every 10 years or so, you'll see a new number after the DSM. We just recently this year have the DSM-5 text revision. So they took the 5th edition that was launched in 2013 and they revised some things. So it's really important too, as we're thinking about diagnoses, that we're also using the current nomenclature, the current way of thinking about disorders, and also as professionals that we're all a part of a system that is progressive and recognizing change. So that was a good shift to incorporating mental health in our diagnostic classification system, but there were still problems because the mental health disorders that were recognized really were capturing the needs of our school age and our adolescent children, but they weren't recognizing that mental health issues exist in our very youngest. So in 1994, 0 to 3, if you want a website looking at kind of work with young children, 0 to 3.org is a wonderful resource. It has a lot of, they do just amazing work, including informing policymakers about the need to pay attention to some of our youngest and most vulnerable. And in 1994, they launched the Diagnostic Classification System for 0 to 3. And that was a book that really gave definitions and kind of descriptions for disorders in children under the age of 3. That was revised in 2005. And then in 2017, they made a new revision and decided to extend the age to 0 to 5. So we currently have the DC 0 to 5 classification system, as well as our DSM-5 text revision as kind of our go-tos for looking at childhood disorders. But I think we can all feel good knowing that we are really matching the developmental levels and ages of children when we're thinking about what's going on with them, as opposed to trying to look at criteria that's really meant for an older child or an adult and trying to figure out what's going on there. One of the, as I mentioned, the 0 to 3 organization and others are really trying to inform policy to make changes because we do important work and it's important that we get paid, that we get reimbursed. And so far in most states, the DC classification system is not something that is reimbursable by most insurance plans. So there's still a lot of work to be done, but a lot of good things are happening, including a crosswalk system whereby you can look in your DC 0 to 5 to help understand and describe what's going on in a youngster, but then map on the crosswalk to see, well, what code would I use to bill if I am using the DSM, or what code would I use if I'm using the ICD-10? So it's a really helpful way of still capturing things kind of more developmentally appropriately while also getting paid for the work that we do so we can continue to do the work. And here on the left side of, or my left side of the screen here is some common disorders and classifications that we talk about when we talk about the youngest kids there. And you can see the example of the sleep, eating, and crying disorders, recognizing how important it is to be paying attention when those things aren't happening. They're not talking about poop here, but that's, of course, another important one, I think. When we're doing a diagnostic assessment of a young child, I think it's very important that we have a broad lens and that we think carefully about what's going on with the child and with the family system. And equally important is that we aren't thinking about things from from just one perspective, that we're looking broadly and we're asking questions that cover a lot of areas. Specifically, we want to make sure that when a child comes in with a behavior concern, that we're paying attention to and asking questions about medical history. So for example, if a child's not talking and they haven't had their hearing checked since birth, well, maybe it's a progressive hearing loss. So that's an important thing. We want to rule out medical issues. Also, we want to ask about stressors and toxic stress in particular. Is there anything that's gone on in your family that maybe could explain why the child is having difficulty? So it's important to bring questions about trauma exposure into the conversation and to create a safe space where the person and the family that you're working with feels comfortable sharing some of maybe their darkest moments. It's also important to understand the different kinds of trauma, the different types of trauma that exist. So there's acute trauma, and that is typically talking about something that's a single event. So maybe a car accident or a one-time, a time where the parent just kind of maybe slapped the child and it was a single event. Then there's chronic trauma. So that may be ongoing exposure to physical abuse or ongoing exposure to parental domestic violence. Then there's complex trauma, and that could be ongoing exposure to a traumatic and toxic stressful event, typically involving somebody that is very important to the child. So understanding the different kinds of trauma is an important part of the assessment process. Another thing that I think is very important when we think about trauma is realizing that not everybody sort of interprets or responds to trauma in the same way. And I like to use the example of, let's pretend that we were all in the same room together. And the ceiling tile, I have these exact tiles that you can see in the picture in my office here. The ceiling tile, a piece of it just falls to the ground unexpectedly, right beside us. We weren't expecting it, and it just happened. Well, for some of us, that event could be not a big deal. Maybe you're sitting here and you're just kind of annoyed because you're like, well, I have to clean that up later, that kind of thing. But you're able to go on and continue to pay attention to what we're talking about. Maybe others of you, had that happen to you and you're really kind of stuck on it. I continue to talk on and go through the slides, but you're still thinking about that ceiling tile and what happened. Is it going to happen again? And you're just a little bit bothered by it. Not to the point of not being able to attend, but just a little bit of a preoccupation. Then others of you, maybe that happens and you just, you can't stay in the room. You have to leave. Or you go home tonight and you're still thinking about that and worrying, is this going to happen again? Maybe it triggers something similar that happened unexpectedly for you. So it's important to recognize that no matter what the traumatic event is, that people perceive and respond to things differently. And we need to pay attention to that. We need to pay attention to the child's temperament and their personality, how they're interpreting what may have happened. And then we also, really important, need to pay attention to the caregiver, because when you work with young children, you're not working with just the child. You're working with the child in the context of that caregiver-child system. And so we have to be asking questions and raising our awareness about the caregiver's own history. We talk about the ghost in the nursery. We ask, parents about their own childhood and what was that like? Because if they had traumatic experiences, that's going to impact how they parent their child. It's going to impact their own interpretation of events when they happen to their child. And it's also going to impact their ability to provide protection and a sense of safety for their child. So all of those things are really important, and it's critical that we don't just put our own kind of judgment on a traumatic event, even if we think it's a big deal or we think it's not a big deal. For this particular child and family, we need to know what's going on for them as individuals. If you want to learn more about trauma-informed work, there's probably no better spokesperson than Dr. Nadine Burke. She's a physician, and she was actually our first Surgeon General of California, and she's done some amazing work. And I think, the state of California, we can be really proud in general about the trauma-informed work that we're doing. And Dr. Burke really was a champion in a lot of this, in the efforts to infuse a trauma-informed assessment to any work that we're doing. Even if the family isn't coming there because of trauma, we're still bringing that up. So if they're coming to a medical appointment and Dr. Burke is a physician, making sure that all physicians are asking questions about trauma is something that she championed. She had this initiative that was launched in 2019, so not too long ago, where through ACEs Aware, which again, if you want to look on a website, they'll tell you a lot more about the work that's been done there, but it's also the place to go where you can receive training on how to use a tool that will allow you to ask a family questions about their child's, the possibility that their child has experienced some kind of a trauma. So they provide a tool, the state of California provides a tool, they provide training for how to use the tool, and then they pay providers $29 for using a simple tool. And then there's also all of these resources that are available to providers and to families for helping children who are experiencing high levels of toxic stress and adverse childhood experiences. I'm sure most of you have heard of the ACEs, adverse childhood experiences, and that is in large part because of some of the work that was done right here in our state. And I think even more kind of cool in terms of things being local, here in San Diego, we actually can be proud to say that we had professionals who many years ago actually really raised awareness about the adverse childhood experiences. And Dr. Vincent Felidi, who was a Kaiser physician, is somebody who started and kind of stumbled upon in his work with obese individuals. He stumbled upon this correlation between individuals who are experiencing significant mental health, and other kind of socioeconomic issues and struggles. And that correlated with high numbers of adverse childhood experiences. And so, as you can see here with this slide, we learned through his beginning work and then subsequent work that's gone on with ACEs that adverse childhood experiences are associated with some of the most devastating medical and mental health and costly conditions, with cardiac issues being one of the highest and most costly ways that it impacts. And if we look at people with cardiac issues, they are more likely to have a higher level of adverse childhood experiences. And so that's an important thing that we need to recognize, because in treating some of these medical conditions, if we're not identifying the childhood trauma or the trauma that's going on, we're really missing and getting off course in terms of our treatment. So Dr. Felidi has kind of got us started. Dr. Nadine Burke and others have kept it going. And now we have a specific tool that took the ACEs survey that Dr. Felidi designed when he first was doing his work in the 70s. The Adverse Childhood Experience Survey was incorporated into what we now call the PEARLS, the Pediatric Adverse Childhood Experiences and Related Life Events Screener. And this is a tool that is specifically designed for younger children. And so it asks very poignant questions. And you can see some of them here. The questions, it's a short survey. It's just kind of a one-pager on one with the ACE questions, and then a second page with some more questions that are really looking at some other specific kind of toxic stressors like neighborhood violence and discrimination and other really important things that are definitely creating stress in our world. But this tool is an easy thing to administer, and it allows us to bring the conversation about trauma into whether it's a medical appointment or a therapy session, and to help us really make sure we're understanding what's going on with the child. So this this PEARLS tool is available through ACEs Aware, and you just have to go through a training that just takes a couple hours of your time to get certified. And then as a professional, you're able to administer this. And it's really, like I said, a nice way to make sure that you're not overlooking the fact that the family may be coming to you with one thing, but actually what's really driving what's going on is the fact that they've experienced trauma and no one's paid attention to that piece of it. This Measure the PEARLS is available in 17 different languages online. and there's different versions. So there's a parent self-report that asks questions similar to our ACE survey that was first designed. And there's also a tool for children from birth all the way to age 11. And basically, when it's for the child and in the work that Yanin and I do, we're asking the parent to be the voice for their child and to endorse whether or not they've experienced any of these events. So it's a measure we use with all of our children, regardless of age or presenting issue. It's our way of making sure that we're not overlooking a traumatic experience that may be really the secret to understanding what's going on and helping them. Other tools that are out there that are normed on young children are listed here, and we'll just put it here as a reference. In our work, because we work with children births to 5, we like the trauma symptom checklist for young children, the TSCYC there at the bottom. It's normed on kids as young as 3. And what's nice about this next layer is I like to use the pearls to start the conversation about events. And then if I'm wanting to understand a little bit more about the symptom presentation, I'll administer the trauma symptom checklist to help in identifying, a little bit more about the specific symptoms. And I'm using that in combination, of course, with other measures as well to understand what's going on, but that being a really important part of my protocol. So a trauma-informed approach is super important whenever you're working with a young child. We need to be asking the questions. We need to understand the impact, the child's perception, the parents or caregivers' perception of what happened. And we need to make sure that we're integrating it into our work. We need to make sure that we're being very sensitive and careful when we're talking with families, because if they're trusting us with their story, and it's a hard story to tell, we need to be able to have created that sense of safety and security that they want to tell us. But we also need to ask the question, right? We can't just wait for them to tell us. So sometimes families will come in holding information, but if we don't ask them, if we don't bring that topic into the room, they're not going to tell us. So that's a really important part of the job that we're doing. And I think the other piece is recognizing our own experiences, whether it's our own traumatic experiences that we might bring and how we might be triggered in our work with children and families who've had difficult paths, but also our role as providers in thinking about the work that we're doing. So for example, yesterday I was seeing a child, and the foster parent and the birth parent were both in the room, and the child was super dysregulated. And I had to think about the fact, and I brought up I brought the conversation into the room about the fact that that for this child, there were 2 very important people present in the room, right? There was the foster parent, the resource parent, and the birth parent. And typically for this child, they both weren't together in one setting. And so, from his little perspective, this was odd and it was uncomfortable. And potentially that was why he was having such a strong reaction. So I think about things like that and really want to understand what's happening in the room that might be different. Thinking about things like, I wear a badge. And so if I'm an unfamiliar person wearing a badge, that may be for this child a reminder or a trigger of the time that somebody came in looking professional, wearing a badge, came into the home and removed them from their parents' care. So thinking about all of those pieces and the role that we may be playing in the child's kind of story and helping them to get to the next level is very important.
So how is early childhood trauma unique? So we have to think about this from a variety of different sort of like factors or perspective. Well, first of all, young children and babies really experience their world, or they learn, about their world through their senses a lot, right? We see younger kids mouthing things. We see babies crawling. They're constantly touching things. So that's really how they learn and get to know their surroundings. So when there is a trauma or an aversive experience that happens during that early childhood for them, it really heightens their arousal level and it really increases their sensitivity to all these different stimuli in their environment. So as a result, as Megan was saying, that we have to understand that different children have different temperaments. So some of them might become more reactive to their environment, or they get scared really easily. They get startled really easily when there's the slightest noise, or some of them might become a little bit more withdrawn. So whenever there's a stranger or even just people that they met once or twice before, they might get really, really attached or really clingy to their caregiver, and then they don't feel comfortable or safe enough to really go out there and explore the world. And also, you know, when we're working with young children and babies, they're at a stage where they're very vulnerable. They might not necessarily have the language development to really express how they're feeling, especially in the setting that Megan and I work at. You know, we are constantly working with children or young children that have a language disorder or they have a language delay. So they're not really able to communicate how they're feeling. And I think the ability to really understand your emotions and being able to express that, that's a really complicated skill to master. Even as adults, we sometimes have a hard time really differentiating, am I happy or am I angry? And then we know that we could feel all these different experiences all at the same time. So imagine, as confusing as it is for us, how would that make a 3-year-old feel? Especially when they don't have the capacity to really express that they're feeling all these different things at the same time. So it's really overwhelming and really confusing for them sometimes. And it might make them feel really helpless. And imagine now if they don't feel comfortable asking for help to begin with because of what happened to them, you know, the amount of stress that they experience, it's just really hard for us to comprehend. And also research has shown that a lot of these early sort of like childhood traumatic events have been associated with a reduced size of the brain cortex. So from a neurobiological perspective, our cortex is the least developed part when we were born. So in those first few years that after the baby was born, that's really a time where our brain is rapidly developing. So imagine now you have this really aversive experience and then you become really sensitive and then you're not getting as much exposure as you would to really help your brain develop. Or you're becoming really sensitive to all these different things in your environment. And imagine, you know, how that's going to impact your brain or how the different cortex or the different parts of the brain interact or talk with each other. So research has really shown that, you know, those early aversive experience really changes your brain functioning fundamentally. And also, you know, thinking back at, you know, when you were younger, you were probably always, you know, when you started crawling, you were always looking back at your parents to make sure that you're okay, right? We're doing that social referencing. Whenever we're in a really unfamiliar environment, we're not really sure how to act. We're looking towards other people to see how we should behave ourselves. So with young children, they're really at a stage where they're depending on their caregivers or adults that they trust in their environment a lot, you know, both physically and emotionally. So again, thinking about if there has been a traumatic event and there is no emotional buffering, meaning that they don't have that support from their caregivers or, you know, adults in their environment, it really interrupts their attachment with their environment. And then we know that research has shown that these earlier attachment patterns really have a significant impact on how we form our long-term relationships. So someone that has a more disruptive or disorganized attachment pattern when they're younger will likely have a harder time kind of forming those meaningful relationships when they become an adult.
Okay.
Now, so this is something that we would love to share with you guys. So this is from Dr. Bruce Perry, who is a psychiatrist and has done extensive research on kind of childhood mental health. So in his most recent published book called What Happened to You, he specifically looked into how the first 2 months of a child's life can have, or the kind of impact it would have on their long-term development. So he specifically pointed out that we need to look at the impact of adversity and also that relational health. So the relational health is the kind of like the blue cloud that we see on the right, and then the adversity is the black cloud that we see on the left. So ideally, what we want to see is high connectedness and low adversity. So that's kind of like the blue dashed line that we see in this graph. So when we have low adversity and then really high relational health, meaning that the child has a secure attachment with the caregiver or with the adults in the environment, what we're really seeing is that the balance of the developmental risk is tipped in the direction of their lower risk, whether it's for mental or social or physical health problem. And on the other side, if we have really high adversity and very low emotional buffering, so that's kind of the blue, or sorry, the black dash line that we see in this graph, then we're seeing a much higher risk for developmental delays and also significant problems in their overall health. And then in his book, he really talks about that. The basic finding is that the experience of the first 2 months of life have really a disproportionately important impact on a child's long-term health and development. And then this really has to do with the rapid growth of the brain that we talked about earlier, really early on in one's life. And then really the organization of those all important core regulatory networks that our brain has. So he then talks about if in the first 2 months of your life or of a life, a child experienced high adversity with very minimal relational buffering, but was then put into a very healthy environment for the next 12 years, their outcomes are still worse than the outcome of those children who had low adversity and healthy relational connection in the first 2 months, but then spend the next 12 years with high adversity. So just think about that for a moment, just that first 2 months, if they had gone through anything that's really, significantly aversive and with minimal emotional buffering, not a lot of support, and even if they were put in a really healthy and stable environment for the next 12 years, their outcomes are still not better. It's actually worse. So just think about that, right? I know it sounds really discouraging, right? It sounds really, especially as clinicians or as parents, as caregivers, it sounds really discouraging, but really, I think this is a perfect example of why we need developmentally informed trauma-aware system in general. Just because a child has been in a stable environment, it does not mean that the trauma no longer impacts them. And then that's why we need to continue assessing and monitoring these symptoms and really asking those questions and really taking the impact into consideration from a longer term perspective. And also, I think this is another good reminder or really emphasize the point that it's never too early to start, right? For example, if we know a pregnant mother has gone through significant stress in her pregnancy, and now she has a baby, and now we know how important those 2 months are. And usually, I don't have kids myself, but I'm sure like all of the parents know how hard the first 2 months are, especially if your baby is not sleeping, if they're not eating, going back to kind of like the wellness signs that Megan was talking about. If they're not doing a lot of that, imagine the stress it has on the mother and how that's going to impact the mother's relationship with the child. So if the mother is not feeling physically or mentally well, how do we expect her to create a safe and sounding environment for the baby so that the baby can focus on growing? So again, it really speaks to the point that it's never too early to start intervening. And we need to do everything that we could so that we don't wait, and we shouldn't wait. And then we should be really helping these parents and these families as soon as possible.
And I'm just so glad that this is something that we're talking about, because I know when I first heard it, like how important the first 2 months are, that just kind of blew me away, honestly. And it really changed my thinking, because I think, even when you work with really young infants, there's not a lot of measures that we can use to adequately assess development that young. There are some, but it's hard to do. And we know that, the older they get, the more they do. So when they're 1 and 2 months old, we don't have a lot of, expectations for them. And yet we need to know how important it is to make sure that they're safe. And that, as you said, like we're really paying attention even before birth, to the pregnant parent and talking to them about, how they're doing, and to make sure that we're helping them, and not just saying, oh, well, they were so little when that happened, they probably weren't affected. We know that that's not the case now.
Absolutely, yeah. And so now, we know how important it is to continue to assess all these different symptoms, like, given the uniqueness and then the huge impact those early childhood trauma has. So how do we assess for that, especially when we're working with younger kids or babies, or kids that are not able to really express themselves? So, the other unique thing about all these trauma is, or these aversive experiences, is that a lot of times they manifest in different symptoms and behaviors that we can physically observe and see. So some of the common symptoms or behaviors that we see when there has been exposure to trauma is that, we're seeing that the kids are, or the children are doing behaviors that we would expect to see for someone that's a lot younger. So things like flicking their thumb, wanting to, take their blanket with them all the time, and just in general more immature behaviors. And also, if they start to lose some of the skills that they know how to do before, so things like language regression, or becoming just really sort of like not being able to do a lot of the things independently. So skill regression is definitely a really big warning sign. And also, if we're seeing like more apparent behavior changes, are they becoming more anxious when it's time to separate from the parents? Are they becoming more dependent? So even if they know how to put on their shoes, they're insisting the parents help them to put on those shoes. Or how are they responding to a lot of things that are happening in their environment? Are they becoming more aggressive? Are they becoming more socially withdrawn? Or do we see any changes in their emotions? Or what about their self-regulation skills? Are they becoming more aggressive, or are they having a hard time soothing themselves? And also, again, going back to some of the wellness signs that we see, are they eating enough? Are they sleeping well at night? Are they having more nightmares? How is their bowel movement? So these are all the different things or the behaviors that we typically see with kids that have been exposed to trauma. And also, the other thing is, we have to think about the timeline of all these behaviors that we see, right? So when did these start? If we know there has been an incident of trauma, when did these behaviors start? Did they start before or after the trauma? If they did before or after, how soon before or how soon after? How long has it been going on? And also, what was their baseline like? If they're becoming a little bit more anxious, how were they before when they get dropped off from daycare, when it was time to separate from the caregiver? So we really need to be asking all these questions, and it shows the importance of that thorough assessment that Megan was talking about earlier. And then a lot of times you might not even get all these informations right away, or just during that initial assessment. Or sometimes, if we're working with a child that's currently in a resource home, the resource caregiver might not even necessarily have all of that information. So again, it just speaks to the importance of that ongoing thorough assessment. And just a little bit more on the effects of trauma. So thinking about it from a neurological or biological perspective, we kind of talked about this already, about how these traumatic experiences can really impact our brain functioning or how our cortex is developing. So it really creates that disruption in our regulatory rhythm, so how we respond to our environment. And then sometimes it leads to fundamental changes to our structure and in a function of young children's developing brain. And then a lot of times what we see is, again, going back to the wellness side, when kids have been exposed to trauma, we often see them kind of having more somatic symptoms, especially when they don't have the capacity to understand or express themselves. We see that manifest more in physical symptoms. So things like a headache, getting sick more often, and then also just an overall increase in medical problems. And it also has an impact on their self-regulation. So, you know, with a lot of kids, what we see is that they're having a hard time regulating their emotions in the first place. And then they have heightened arousal. So they're becoming more and more sensitive to all these different things in their environment. And then again, we talked about, you know, that difficulty with understanding, knowing, or really expressing how they're feeling, you know, to other people or like to caregivers. And also from an attachment perspective, we talked about this a little bit earlier, but you know, an interruption or disruption in those earlier attachment patterns really becomes a barrier for them to form those trustworthy relationship as they get a little bit older. So as Megan was saying, you know, when we're working with kids, we have to think about, you know, how do they perceive us? You know, if they were involved in domestic violence before, and then they're working with, say, a male or maybe someone that's a little bit taller that reminds them of the perpetrator, how would they react in that situation? So again, those earlier events really have an impact on how they're perceiving others in their environment, and then their ability to really form that healthy and secure relationship. And lastly, from a developmental perspective, we talked about this, you know, with that skill regression. So with a lot of kids, we often see them losing the skill that they know how to do before, and then that really leads to a disruption in their developmental progress. And, you know, one of the things to think about is what is what is developmentally appropriate? And that's really something that we kind of have to think about when we look at the behaviors that a lot of these kids are exhibiting. You know, if you have a 2-year-old who is showing some signs of separation anxiety because they have never been to preschool or daycare before, that's probably typical, right? We would expect to see that if it's the first time that they're expected to separate from their caregiver. But what if we're working with a 10-year-old, you know, who just for the last month has just been refusing to go to school because he doesn't want to separate from mom? You know, so that may make us think a little bit more about, you know, what happened there. You know, if he was fine before, what all of a sudden changed that made him a lot more anxious, a lot more clingy, and then really regressing to some of the behaviors that we would expect to see with someone that's a lot younger. And just some more on kind of the effects of trauma. With social, in terms of like social relationship with other people, and because again, kind of that interruption or disruption in their attachment pattern, what we see a lot of the time is that depending on the children's temperament or their personality, they react differently. So some kids might become just more socially withdrawn, where they're less motivated or not wanting to interact with other people in their social environment. Or with some kids, we see them just really kind of not knowing boundaries. For example, not being able to differentiate how they should be acting with someone they know versus someone they first met. So these kids might be overly friendly and are really kind of not knowing how to set boundaries and how to maintain those boundaries. In terms of their behaviors, often we see kids will have you know, for impulse control, or we might see an increase in their self-destructive or injurious behavior, especially when they're having a hard time regulating their emotions. They don't have enough coping skills, and they're not really able to express how they're feeling. And then from a cognitive perspective, with a lot of these kids, especially when the trauma has happened like pretty recently, we see a lot of, we see the impact on their learning, especially, and on their attention, their ability to really focus on completing different things. And then that leads to, you know, another sort of like range of learning difficulties, especially once they start enrolling in school. So things like difficulties with reading and math, or just language development in general.
As we've said, when you're working with a young child, it's so, so important to pay attention to the child in the context of that relationship with their primary caregiver. It's so critical. And experts in the field of child development talk about the fact that when something happens and there's a traumatic event and development is interrupted, it can't just pick up and keep going. It stops. And we see the impact of trauma in our offices every day. And it's really important that we're recognizing it for what it is. This video here that I'm going to share with you, it's called the still face experiment. I'll warn you, if you haven't seen it, it's a little hard to watch, but I think it really highlights how we are social beings from such a young age, and how we do depend on those important people in our young lives to respond to us, and what happens when that doesn't happen. And I think that highlights the importance of the various kinds of child abuse that are out there. There's physical abuse and sexual abuse, and those are terrible. But neglect is also a terrible form of abuse. And I think it's demonstrated really nicely in this experiment here. So I'm going to share it with you now. Here we go.
Babies this young are extremely responsive to the emotions and reactivity and the social interaction that they get from the world around. This is something that we started studying 30, 40 years ago, when people didn't think that infants could engage in social interaction. And a still face experiment that the mother did was she sits down and she's playing with her baby who's about a year of age. And she gives a greeting to the baby gives a greeting back to her. This baby starts pointing at different places in the world, and the mother's trying to engage her and play with her. They're working to coordinate their emotions and their intentions, what they want to do in the world. And that's really what the baby is used to. And then we ask the mother to not respond to the baby. Baby very quickly picks up on this. And then she uses all of her abilities to try and get the mother better. She smiles at the mother. She points because she's used to the mother looking where she points. Baby puts both hands up in front of her and says, "What's happening?" She makes that screechy sound at the mother, like, "Come on, why aren't we doing this?" Even in this 2 minutes, when they don't get normal reaction, they react with negative emotions. They turn away. They feel the stress of it. They actually may lose control of their posture because of the stress that they're experiencing. Something like good, that normal stuff that goes on that we all do. Bad is when something bad happens, but the infant can overcome it. After all, when you stop the still face, the mother and the baby start to play again. The ugly is when you don't give the child any chance to get back to the good. There's no reparation, and they're stuck in that really ugly situation.
Just going to get us back here. Can y'all see that?
Yes.
Okay.
So now imagine if we didn't know that there was that still face experiment. Imagine this was the environment that the baby grew up in. So, what we see is a baby that has very limited range of expression. Maybe they're not as responsive to, when you are approaching them, when you're saying hi to them. And then maybe they're just not really interested in social interaction in general. So what does that remind you of? Maybe someone on the autism spectrum disorder. So, when we're working with younger children, it's again, talking about 0 to 5 age range, there are a lot of commonly seen developmental disorders that have really significant overlap in terms of their behavior and their presentation when we compare them to kids that have gone through those traumatic life events. So again, we're going to be doing a very brief overview on some of these commonly seen developmental disorders. Every and each one of these could be a talk or many talks in themselves. So we won't be spending too much time on these. So with autism spectrum disorder, right now it impacts about 1 in 44 children more commonly than in boys and girls. And some of the core features that we see with kids on the spectrum is they struggle with maintaining social relationships. They have a hard time picking up nonverbal communication or social cues, and a lot of them present with restricted interests or repetitive behaviors. And the other commonly seen with this age group is attention deficit hyperactivity disorder, which is a persistent pattern of inattention or hyperactivity or impulsivity. So some of the common behaviors that we see are, they need consistent reminders to complete an activity. If you ask them to get dressed, it might take them 45 minutes or an hour because you're constantly getting distracted. They need you to remind them, every 5 minutes to do it, or they're not really able to sustain their attention or really remain seated for what's expected for their age when they're presented with a structured activity. So some of the things to think about with diagnosis of ADHD is that it's not common to give a diagnosis of ADHD, or it's not really recommended to provide that to a child under the age of 4, just because there's a lot of overlaps in terms of their behaviors, especially thinking about that inattention and hyperactivity piece with children under the age of 4. So really kind of thinking about what is developmentally appropriate for that age and what really constitute them meeting the criteria for ADHD. So again, some of the things I want to point out is that a lot of these symptoms have to be present before the age of 12, and then they have to occur in 2 or more settings, and then they have to lead to significant impairment in their daily living functioning. And it is not really explained by any other mental health disorders or medical reasons. And lastly, we want to just briefly touch on fetal alcohol spectrum disorder. So as a community, we're doing a better job at screening and asking different questions about alcohol use. So of all of the substance people abuse, including cocaine, marijuana, or heroin, alcohol produces the most serious neurobehavioral effects in the fetus. And then right now, there is no predictable correlation between the amount of alcohol exposure and then the likelihood of development of a fetal alcohol syndrome. So in other words, there is no safe amount, there is no safe time, and there's no safe type of alcohol. And just really, again, quickly, some of the criteria for fetal alcohol spectrum disorder, individuals usually present with that facial characteristic. So the small eye opening, the smooth philtrum, and the thin upper lips. And really with fetal alcohol spectrum disorder, we're also seeing a lot more impairment in their structure, a neurobiological and their functioning. So with younger babies, we might see them becoming more irritable, taking a really long time to be soothed, or just not really being responsive when the caregivers, are engaging them. And then with some of the younger children, we're often seeing a harder time with executive functioning, issues with attention, sometimes learning, and also quite significant difficulties in their emotional regulation.
I would say one of the resources that we shared with you guys is an article by Ira Chasnoff that talks about the overlap in symptoms. It's just really, it specifically talks about ADHD and the overlap with fetal alcohol spectrum disorders. I think we see it also with autism spectrum though too. There's just a lot of shared characteristics, and it can be really confusing and important, I think, when you're just kind of sitting there going, I don't know what's going on. Everybody's talking about autism, but it feels different. There's something, I think, else going on. I think it's important that we've asked the questions about alcohol exposure and considered that as a possibility, because that certainly could inform treatment planning in a different way. We did want to also talk about childhood depression. And we know that really little babies can be depressed. It just looks differently. So here are some questions to ask if you have a really little one in front of you, and to make sure that you've really thought about the why that it's happening. So are they kind of frequently staring off into space? Well, we want to consider medical. Is that, are they having seizures potentially? Or is it maybe that they're just withdrawn and kind of checking out? What is their facial expression looking like? Are they smiling? Because we know at about 6 months, we start to see that responsive social smile, or we should be. So if we're not seeing it, what's going on? Is it autism? Is that an early sign of that? Or maybe they're having just some mood issues as a really little one. Are they expressing a range of emotions? Does the caregiver recognize different cries? Are you able to engage them socially? Are they really quiet? Are they starting to vocalize? Well, that could be the beginnings of a language disorder, but it also could be something more emotional. And we know that babies should not be crying, because the language of babies is to cry before they can talk. And so if they're not doing that, if they're too good, then that's not okay. And we need to pay attention to the absence of things as well as the presence of things. Also looking at their toy play. Are they interested in toys? Are they playing with the toy as we'd expect? And is there any change in the way that they were presenting compared to before they came to your office? So really getting a good baseline. Even if they're only 6 months old, we still want to know sort of what happened before, and if there was any significant changes or events that maybe could explain why they're presenting as they are. Childhood anxiety is another really important topic and consideration. And again, a lot of overlap with some of these other developmental disorders that we've talked about. But I think here it's so important to recognize that while anxiety, a little bit of anxiety is good, right? It's the anxiety of doing well and presenting well for you guys that made me get to work a little bit early and make sure everything was, all the slides were in place and everything was good, because I was anxious. I wanted it to go well. And little kids also are fueled by anxiety in positive ways. But it's that point where it crosses the threshold and interferes with relationships, with learning, with the things that kids should do, that we need to worry about it. I literally was just before this session in a feedback with a mom, and she said, and we were talking about his diagnosis of anxiety disorder, and he's 4. And what she said was, he just doesn't do that. He doesn't have fun the way that in the things that kids should have fun with. So one of the things he really loves to do is to ride his scooter and his bike. It's like his absolute favorite thing to do. And they were having a big kind of parade and bike day at his school, and he didn't want to go, but he loves riding his bike, but it just couldn't do it. And so it was getting in his way. And that was a great example. And she and I both agreed that we needed to do something, because, and we talked about this, if at 4, he's not able to participate in bike day, what is that going to look like at 13? What is he going to be prevented from? What's that going to look like as an adult? So how do we help him in understanding what's going on with him? And then how do we help him to cope and to kind of figure out what he needs to do? He may always be somewhat of an anxious person, but can we help sort of lessen those symptoms? Can we help him know, okay, when I go into a bigger kind of over, like a crowded situation, I get anxious. I know that about myself. So what do I need to do differently in that situation? And as parents, working with parents, we need to help coach them. What are you saying to your child when they respond, with anxiety? What are you saying? What's the language that you're using? And how are you reacting when something happens to them? Are you contributing to more feelings of anxiety and overwhelm? Or are you helping them to learn some really good tools that'll help them, not just now, but throughout their life? So here's some questions to ask. We have some really nice questionnaires actually that are normed on this young age group, and it talks about, asking the parent, does the child have any fears? Do they have things that they worry about? This little guy today was, he just was constantly worried about every little thing. What will happen if this? He didn't want to have a birthday party because he was worried about people paying attention to him and sharing the spotlight. Fortunately, he has a sibling who has a birthday close in age, so mom was able to do the birthday party with the two of them, and he liked that because the spotlight was off him a little. And so that was a really nice strategy that she had. Plus, I told her I thought it was really smart because it meant that she only had to do one birthday party instead of two. And she thought that was true as well. It was a win-win for everybody. Also looking at, maybe some rigidity and order. So, needing things to be just so, the placement of toys, lining things up. Is that something that's going on? And is that a function of something like a neurodevelopmental disorder? Sometimes we see lining and grouping of like objects in autism spectrum disorder, but it could also be seen in children who have anxiety or who need to assert some kind of control in their life. And so it's important, again, that we consider a broad kind of scope of what may be going on. Kids that need a lot of reassurance is also a thing. And then I think, again, young children look to their parents to kind of give them reassurance. So if they go into a room and there's a stranger that comes in, we want to see that child look to the parent and say, hey, mom, this guy, is it okay? That's a positive attachment. But if they're constantly needing that reassurance, when it doesn't seem necessary, that's when we want to be worried. Similarly, when they're separating from their caregiver, it's typical at this age, birth to 5, for there to be some separation difficulties, that they should want to be with their parent and they should have a difficult time separating to a degree. And many do, and there's a continuum. Some actually separate without any difficulty at all. But those that have difficulty, we don't get overly concerned about that unless, again, it interferes. So they can't go to preschool. The parent is getting called at work because daycare is, he's still crying and it's been three hours. I think those are all really important. Or the parent who can't go to the bathroom by themselves because the child just won't separate them even within the comfort of their own home. So those are all ways that we see that kind of the frequency or the intensity of the symptoms and how it's really interfering with whatever it is that the child is supposed to be doing at that stage in their life. Here are just some, and we highlighted, some of the kind of more common questions that we get: autism spectrum, attention deficit hyperactivity disorder, fetal alcohol syndrome, oppositional defiant disorder, anxiety and depression. Sometimes parents will come in asking about an auditory processing or sensory processing disorder, or they'll come in saying, my child seems to have obsessive compulsive disorder or OCD, and they're 2. So, what's going on there? Some children where the parent may come in and say, wow, he's 2 years old and he's reading already. Is he gifted? Maybe some motor coordination issues, frequent falling, walking into walls. What's going on? So it's really important to throw a wide net when any one of these questions are being asked, and to really look carefully and to ask broad questions, not just in one area. So if a parent comes in concerned about autism spectrum disorder, I'm not just going to ask questions about autism. I'm going to ask the broader question. I want to know about the pregnancy. I want to know about stressful events, because that's important. It's so easy to misdiagnose by not considering a broad perspective and doing what I call throwing a wide net over all the possibilities. I remember a little guy that I saw, and this was a couple years ago now, but it's still something that I hold because it taught me a lot. I've been doing developmental assessments for a long time, and I had a little guy come in with his mom, and he was close to 5, 4.5, and we were doing, we did the interview, I did my testing, got some questionnaires, and everything was really pointing to an ADHD diagnosis. And I was pretty sure that's where I was going to go. And we took a break, and I started just looking over the data, which included the Adverse Childhood Experience Survey, which is now the PEARLS, but at the time we were just using kind of a childhood adapted version of the ACE survey that was developed for adults. But on that measure, the parent had endorsed that the child had been exposed to domestic violence. And this was not something that she had shared with me in our interview. And I like to think I asked pretty, poignant questions and pretty detailed questions, and I'm paying attention to what's going on, but that was not brought up in our conversation. And yet I had this tool in front of me. And fortunately, I looked at it and was able to circle back with her and I said, hey, tell me more about this. And she shared how earlier, a couple months back over the summer, the father had been in the home, and he had been physically violent towards the mother, to the extent that the older brother had to step in and intervene. So it was a significant event. The dad left the home. He's now back in the home, got some treatment. It was actually, I said a couple months, but it was actually more like, I think, 9 months. So there was a significant time period, but dad was back. And, I did ask a lot of questions about current safety and all of that. So what it taught me was, potentially what was going on with this child was a traumatic, reaction to a very stressful situation. He had witnessed his father hurting his mother and his brother getting into the mess there. And that very likely this was impacting the way that he was presenting. And so I quickly shifted my focus to a clear ADHD treatment path, to a trauma-informed assessment. And I referred them to mental health therapy for more assessment, looking at the trauma, and was really grateful to that tool that helped me, hopefully help this family in a more comprehensive way, in a more correct way than would have happened if I would have just kept with my ADHD lens. So we always like to tell a good story, and Nathan, and that's not his real name. In fact, this little guy is actually my now 20-year-old son, who is going to help me tell the story today. And Nathan is a little guy that I think presented as very complicated, presented with a lot of the concerns that we talked about with different developmental and disorders kind of coming up as a question. And we did things right with him. And I'll tell you why we did things right. We paid attention to Nathan over time. And we didn't just jump to a conclusion because things weren't clear. Sometimes when kids come in, things are clear, and then we send them on a certain path. But when it's not clear, we want to make sure that we take our time, and we do what I call assessment over time. We look at the child's response to intervention, and we allow ourselves to flex away from whatever we're doing and pivot if that's what's needed. So again, Nathan, I met him when he was 2 years old at first. And there he had just been removed from his parents' care, and he was in a place, a receiving center, where children where there's concerns about abuse, they get removed and they're placed there temporarily until they can go to a resource home, a foster home. And there, and I don't have scores up here for him at 2, but there we use the Bailey scales of infant and toddler development, which is our gold standard for looking at cognitive, language, and motor skills. And he had really good skills cognitively and good motor skills too. His language was delayed. And he was very dysregulated. I did get to talk to mom. She herself, she was present kind of visiting, and she joined the session, which was wonderful. Part of the reason for the removal was substance abuse. She disclosed that she had been diagnosed as ADHD as an adult when she was in college. So all of that was a lot of information, right? So here's a person seeking a college education with substance abuse history and ADHD. And we think about all the overlap between those different kind of issues and how they might have come to play. Was she using substances to potentially self-medicate her ADHD symptoms that hadn't been diagnosed in childhood? I don't know. There was just so many things to think about, but it did impact her child to the extent that he was removed from her care and placed into a foster home. We brought him into our program, had lots of different interventions that were put into place for him, developmental and mental health interventions. Saw him again at 3. And he still, and you can see here, we use the differential ability scale, which is a measure of cognitive skills, looking at different areas. And he still was showing some of those really good kind of problem solving and verbal abilities that we saw at 2. So that was holding steady. Cognitively, again, I saw him at age 5, and he had even higher scores on the same measure, which was really nice to see. So one of his kind of what we call protective factors, and you'll hear more about that soon, was that he is a very bright child. And it sounds like too, that was a really big strength for mom as well. Diagnostically, we really weren't sure what was going on. At age 2, I gave him an adjustment disorder, an expressive language disorder, but I was worried about autism because he presented with a lot of dysregulation. There was some lining up of toys, and eye contact wasn't always great. But I was also worried about ADHD because he was very busy and very impulsive and easily dysregulated. And so all of these were questions, but not clear because he had many things that also kind of contraindicated that diagnosis. And most importantly, because I know the impact of childhood trauma on how a child presents. And I just didn't feel that we would, that it was correct to give any kind of definitive diagnosis. You can see here too, some of the tools we use. So the ADOS is a semi-structured play-based assessment tool. Many of you are probably familiar with it. The autism, the Autism Diagnostic Observation Schedule, which is one of the tools that we use to assess for autism. And here on our tool, he had just met that threshold for autism spectrum as a concern, but I still didn't give the diagnosis. So just because someone meets a criteria on a specific tool doesn't necessarily mean clinically at the end of it, I'm going to give that diagnosis. But just lots more questions than answers. We saw him back again at age 3. The school district had given a clear diagnosis of autism for eligibility in education. I was still seeing some concerns socially, but also there was a lot of back and forth with mom. He had been reunified and then kind of relinquished. She lost custody again. He was back in foster care. So there was still that primary adjustment as a concern. So I saw him at 3, still more questions, more intervention. And at one point I tracked all of the different kinds of therapy that we did: mental health, developmental, educational, care coordination being a huge component of this. And it was just, I think, a way of really looking at him over time. I was fortunate enough to get to see him at 5 again. At this point, he had actually was in a pre-adoptive home with a couple who he was going to be in his forever home. They agreed to have an open adoption. So mom was going to be able to stay in his life and have connection. And when I looked at him there, he did not meet criteria for autism on my tool. And he did not actually have any diagnoses that I felt were appropriate. And his IEP that he had at 3 was actually now closed because he'd met all of his educational goals. So, was everything great? Well, certainly he's a resilient little guy, and his presentation at 5 was certainly really positive to see. But we know a couple things, right? We know that trauma can come up. The impact of his early experiences could come up at any point. So at 5, he wasn't showing a lot of symptoms or learning issues, but he's somebody we're going to want to keep watch, and we're going to want to keep and make sure that the new caregivers are aware of the importance of paying attention to how he does at different time points. So I think that's really important. The other thing I think that's really important here is, all you need is love is a song, but it's not true for these little guys, because we know that you can have a stable home and lots of love and really good caregiving and still have developmental and mental health disorders. And so that's important to recognize too. In this case, it did coincide with his not having any symptoms, and that was certainly a positive, but it doesn't always happen. And I think the fortunate thing there is if you have a stable home, you can hopefully do a lot to embrace and help the child with whatever their needs are. So it's certainly a positive to have that, but it's not a fix.
And we just wanted to end on a positive note. You know, with a lot of these children that have gone through traumatic experiences, they also have the capacity to build resilience. And as providers, we want to make sure that we are supporting them to identify these different factors. So thinking about things from a social perspective, do they have enough support within their immediate family, within their community? And also, how do we help them build their social emotional competence? You know, are they involved in mental health therapy services? Are they learning constantly newer coping skills to help them regulate their emotions? And also kind of understanding child development, thinking about what is developmentally appropriate and then when we should become concerned and then become or like try to intervene. And also concrete support. Are they, do they have their basic needs met? Do they have a roof over their head? Does the family have enough income to, you know, provide food on the table or buy diapers for the baby and things like that? And also, I think really importantly, thinking about how do we help the parents build their own resilience? You know, with a lot of the families, especially in the case of domestic violence, we have to address the needs of the child, but we also have to address the need of the mother or whichever caregiver is left. One of the children I assessed a couple weeks ago, mom was telling me that, you know, his love language or the child's love language is touch, but she feels triggered every single time he touches her because of the incidents of domestic violence. So, you know, how do we provide her the support and make sure that she's sort of like working on her own mental health, working on her own issues while making sure that she's providing enough support for him. So again, thinking about things from parents' perspective and make sure that, you know, we're helping them along the way as well.
So this is our next to the last slide. The last one is we're going to take some questions, and I see there's some Q&A there. So hopefully we have enough time to get through those, but we do want to leave you smiling. And like as Yanan said, end on a positive note. And many of you have maybe seen this video. I saw it first on Facebook and I just fell in love with it. It's a video of a dad and his son. We'll warn you that the volume isn't great, but honestly, you don't even really need the volume because just watch the interaction between the father and the son non-verbally, and you'll see how they do what we call serve and return, which if you think about tennis, like the little boy serves, you know, a vocalization or a comment or a gesture to the dad, and dad is right there responding to him, mirroring him, engaging in him. And this is what we hope for our kids, right? Is that they have this kind of a connection. So enjoy.
Drinking cold water flushes 67 pounds of fat.
Apologies for this. We're going to get through this part. There we go. Hang on one second. Yeah. Oh, did I thank you, Yana?
Yeah.
If you are struggling to lose weight, you need.
There we go.
Maybe work on it, right? Yes. Do you understand it though? No. Oh, not this. I was wondering, I don't know if we're going to be next season. I think it's this time. Oh, yeah. You know what I'm saying? You know what I'm saying? Yeah. Yeah. Like go somewhere else, don't break here. You know what I'm saying? Yeah. He did. You know what I'm saying? And I'm like, what in the world? Don't do that. You know what I'm saying? Yeah.
Watch that all day. So now we'll just take a couple questions. I know we're almost out of time. Apologies for that, but hopefully you enjoyed that last little video there. And hopefully, even though you couldn't hear very well, you got to see the really nice connection and just the value and awesomeness of a strong parent-child relationship or caregiver relationship. We're going to go through the Q&As and maybe address these questions. Hopefully we can get to it in the last few minutes. The first question was by Jennifer. How do I find mental health providers that address the needs of ages 0 to 3 in my local area? And it's a rural area of California. That's tough. And I would say I don't have a good answer there. I think asking families to look at the behavioral health side of their insurance would be one suggestion. And then, seeing if there are providers who, have that skill set for 0 to 3. We do have First 5 funding in a lot of California. So I would look there because they're working with mild to moderate levels of developmental and behavioral concerns. That might be a good resource. Potentially also your kind of early intervention services like Regional Center here in San Diego. We have San Diego Regional Center, and there's different regional centers throughout California. That's going to focus more on development, but there may be also some resources there. But otherwise, I think it's tough. One of the programs that Yanan and I work with called Kids Start Here was developed because there weren't good enough resources for children with these complicated needs. And so, hopefully that will be something that surfaces in your area if it's not there now, because I think that is a tough thing. Carrie asks about that we mentioned eat, sleep, and poop, repeat, but talk about routines. So I'm not sure exactly what the question is here, but I think routines are super important for predictability and for learning. And so that's a really important thing. And we want to have those around eating, sleeping, and pooping. I think a lot of times because it helps children know what to expect and what to do, especially if they have trouble regulating themselves. And we know regulation impacts all of those different areas. So I think routines are often very helpful in presenting that, providing that sense of safety and security that kids need, and that repeated exposure to ways of learning. I hope that answers your question there. Oh, and then Haley would like to answer this question live.
Oh, she did. I can take the next question about the reduced size of the brain cortex. So I think it really depends on when the trauma happens. So for kids that have gone through trauma in utero, so for example, if they have been prenatally exposed to a substance, or if the mother experienced significant level of stress during the pregnancy, so it is a possibility that that could lead to some biological changes in their brain when they were born. And also after they were born, we talked about the first few years. It's a really critical period of time for their brain development. So anything that that's more aversive for them could also lead to like fundamental changes in terms of how the different cortex or different parts of the brain interact with each other.
Yeah, there's actually scans that we've seen in children who've had trauma that show significant visible differences in brain cortex. We'll just do this last question and then we'll end for the day. And anybody who has to go, we know we're over. Have you seen the impact of COVID and shelter in place affecting children? Absolutely. I think, we definitely see it. The place that I think, though, that highlights what we see in a really good example, we have a toddler school program here at our hospital. And what we noticed was we had a cohort of kids all the same age who had all sheltered in place. And some of them were neurotypically developing and others had neurodevelopmental disorders. And what we saw was when they all entered after having been sheltered in place, they the children who didn't have any developmental delays and behavioral issues needed time to adjust. And so they didn't just come back in and pick up where they left off. They did have to adjust, but they did. And whereas the children, for example, autistic children who came back in, they did not show that same period of recovery. And so there was a difference over time that we could see. But I do think that, COVID has definitely impacted us all, and we're just beginning to learn how that impacts the family system and certainly then by design the child. So
And also, I think that's another great, time to think about what is developmentally appropriate and then really the level of severity of all these behaviors and presentations. For a typically developing child, they might need like a couple weeks to adjust to the routine or the old routine. But if we're seeing no improvement in terms of, their adjustment in like 6 months or even 3 months, then we might become a little bit more concerned. So again, just kind of speaking to the importance of like thinking about when it becomes more impacting of their functioning.
So on that note, we will end, and thank you all for being with us this last hour and a half. Have a good rest of your day.
Thank you so much. And on behalf of Caltrin and of course our attendees, I'm sure you'll see the thank yous coming through in the chat like you are now. We just want to say thank you so much for your time, your expertise, and for being with us today. And for anyone on the call, just want to remind you that there will be a 2-day follow-up that will include information such as the replay for today's session. And we'll also make sure to include that survey link in the chat so that you can access your certificate of attendance. Thank you all so much, and we'll see you again.